From the beautiful Finger Lakes region of upstate New York, this is the Dental Lighthouse podcast. We take questions from anyone in the dental profession and discuss what it takes to win not only in dentistry, but in life. Business, leadership, relationships, parenting, health and wellness, money management, nothing is off limits on the Dental Lighthouse podcast. I'm Jason Tanoory, your host, and have over 20 years of experience to pull from. Learn from my mistakes and let me help you collapse time so you can become the best version of yourself. Yo, welcome back. Dr. Jason here, Dental Lighthouse podcast. Super excited about my guest today. I traditionally would read his long, extensive bio, but we want to keep this episode to about 45 minutes or so, and we can't spend the entire time just reading about his accolades. So I'm going to give my ChatGPT summary of Dr. Aaron Nichols' bio, just based on my information. I'm sure there's a lot of things that I'm leaving out, but Aaron and I have been friends for probably 5 or 6 years now. We met each other through Dr. Mark Costas and his coaching group. So we're both coaches for Mark. Aaron ran an extremely successful private practice on the East Coast and ultimately sold to his associate at the time and basically just reversed roles. Now Aaron uses his wisdom and his knowledge and his expertise all over the country to help associates become more productive, to become more beneficial in their practices. And he also, as a quote unquote side project, does a tremendous amount of mission dentistry overseas in third world countries. And maybe we'll have some time to kind of unpack that. But welcome to the show, Dr. Aaron Nichols.
Thanks, Jason. Appreciate it. By the way, it's Nicholas, not a big deal.
But Nicholas. Sorry.
I'm the old saint, like that.
Awesome. Well, I'm just going to call you Dr. Aaron because I can't screw that up.
Okay. Or you just call me Aaron, either way. But yeah, good deal.
So, there's a lot of ways that this conversation can go, Aaron, and I want to leverage your wisdom for our listeners and give them the most value that we possibly can. So, in talking through things with you before we hit record, we thought it would be kind of fun to unpack a list that you've created on the best ways to set up your associate for failure. Joking aside, but a lot of the things that I hear on my coaching calls, I'm sure you hear on your coaching calls, of how founder, owner doctors are treating their associates, a recipe for disaster, a recipe for failure. So maybe unpacking some of those, and then we'll give the counter argument of what we really should be doing to set up our associate for the greatest amount of success that they can possibly have. Does that sound good to you?
Yeah, no, that sounds great. Yeah. And I'd also point out that we got here because I was talking to you about Charlie Munger and how he would always say, if you want to solve a problem, figure out the inverse and then go from there. So it's like, if you want to set them up to be successful, you go, well, what can I do to really screw this up for them? And then you go from there and everything becomes a lot more clear at that point.
Amen. 100% agree with that. And, speaking from experience, as the listeners know, I have a lot of associates and I've really screwed this whole process up many, many times. And I feel like I've got it fairly dialed in at this point, but if there's people out there listening that are considering their first associate or have one and maybe moving to two, this knowledge could be exponentially beneficial for them in terms of collapsing time and getting to where they want to be at a much shorter runway than I personally experienced. So let's start with your list, Aaron. Give me one of the ways that most of us owner docs are setting our associates up for failure.
Okay, I created a list that went with the talk that I did. And I think probably number one, I would say, is don't create some sort of an onboarding plan for your associate. Let's just go ahead, we'll hire him. If he's the right guy, it's going to work great, or girl. And if it doesn't, then it's definitely the associate's fault, and all associates suck, and we need to move on and get another one. And where do you find good associates? I think a lot of times people don't take responsibility for the pieces that they have some control over. So number one, don't create an onboarding plan. Just expect that they're going to figure it out.
Yeah, 100%. Again, just speaking from own personal experience, one of my early on associate failures was because of just that. I just assumed because this was a doctor and graduated from a dental school and had a license, I would throw him in a room, give him some supplies, and off you go. And as you can imagine, that relationship ended quickly. And at the time, I was so ignorant that I thought it was his fault, right? And in actuality, it was my fault. So, if we're going to do the right thing and we're going to try to onboard someone the right way, can you just give me a few nuggets on how you feel we should best be onboarding a young, eager associate to join our practice?
Sure. Just one more word about just on the onboarding process in general. So as doctors with experience, we have gone through the whole learning process a long, long time ago. And a lot of times we forgot what it was like to be an associate. So, I mean, one of the reasons I do that I do what I do is because I remember my first 5 years in dentistry, and I was actually a practice owner. I did a scratch start right out of school. And so there was not even the opportunity to be an associate at that point. And I just remember how painful that was, trying to figure it all out on your own, et cetera, et cetera. So if we're looking at onboarding our associate, the first thing is they don't really even know how to work in an office. They've been in dental school. Their appointments have been 3 hours long. And every step along the way, someone has come along and gone, uh-huh, that's good enough, or that's not good enough, and then told them what to do. So now they've come out of school and they literally have to create their own standards for what's okay and what's not. I've been working on this tooth, I've been taking out decay or whatever. When am I sure that I have got all the decay out? Or do I care? Or how much time do I want to spend? Or, all of those things, they've got to start to figure out what their standards are. And for me personally, that was one of the things that kind of drove me crazy because I've got a bit of a perfectionist bent. And so like nothing I did was ever good enough, because you remember in school, nothing you did was ever good enough. But at some point they go, okay, that's good enough. Go ahead and move to the next stage. So they have to start and go through that process. So as we're bringing them in and starting them through the process, we kind of have to let them get some sort of an idea of, what's our standard in the office? What kind of work are we expecting them to do? This is okay. This is not okay. So things like getting some x-rays that show restorations with overhangs versus restorations that don't have overhangs, crowns that have open margins versus crowns that don't have open margins. When is an endo good enough? How close does it have to be to the radiographic apex for us to be happy? Or is that even a standard we want to uphold? Or would we rather go with what the apex locator says? And how do we differentiate that? And so just those bits and pieces of how do we decide, what's going to really be our standard here in the office, I think is super important, and that can even extend to how do we expect our patients to be treated? How do we want them talked to? How do we refer to other doctors when we're cleaning up somebody's work, if we have to do that? And is it different for if they're in our practice or outside of our practice? So all of those different things, and everybody brings a different bent to that, but we need to have sort of a standard within the office that we're working at. And for sure, you have some standard that you expect. And if they comply, if they are the same as your standard, then, oh, they're a good doc. And if they're different, then they're not a good doc, but we haven't communicated to them, what standard we want to see. So I think it's really important to kind of communicate those standards right from the get-go so that we're all on the same page.
Yeah, so much wisdom there to unpack, and I 100% agree. As I've become more successful with onboarding associates more recently, everything that you just said really resonates. So we got to be crystal clear with what our expectations are. We call it calibration, but to your point, we could talk about clinical calibration, we could talk about patient experience calibration, we could talk about clinical efficiency calibration. And unless we communicate to the associate what our expectation is in regards to those levels of calibration, then it's our own fault if they don't become successful. And I truly believe that the first month or so, now it depends obviously on the age of the associate. If it's someone's been out of school 5, 6 years, it's a slightly different onboarding process. But most of the associate dentists that we are lucky enough to bring on typically have 2 to 3 years of experience. So they're starting to figure out that they don't know everything. And for those associates, we put them through typically a 2 week strict observation protocol. And whenever I have that conversation with the associate, they kind of balk at it. But it's paid, it's expensive, but it's just been my experience that when they follow you around the office for, say 2 straight weeks, so many things become um, enlightened to them. Oh, I had no idea this is how dentists talk to patients. I had no idea this is how you present treatment plans. I had no idea this is how you get in and out of a hygiene exam quickly. I had no idea on how you're supposed to communicate with an assistant. So you can learn a lot through observation. So in my opinion, the first part of the onboarding process should be some level of observation where they're just not thrown into a room with a rookie assistant and say, go produce some dentistry for me.
Yeah, I mean, and the other thing too is depending on where their experience is, they may, what you're doing or what you're saying or the way that you're doing things may have never occurred to them. And they go, oh my gosh, that's so easy. That just makes it so simple to figure that out. I have in the past had younger docs say, hey, would you be willing to come by my office and let me know what I need to do? And it's like, that's actually the wrong way to do it. You should come by my office, come hang out for a day and see what things seem important to you for two reasons. Number one is I can't, by walking into your office, magically see what's wrong. Okay. Number two, by coming into our office, you're going to see a way of doing things that may have never occurred to you that you're like, oh my gosh, that's just so much easier than what I've been trying to do, or that thing solves the problem. And most of the time, I'm not going to know that because I've been doing it this way for so long. This is normal to me. So your
Right.
young associates coming in, even though they only have a couple, 3 years of experience, they have a way of doing things that's their norm. Whereas when they come in and they see you working, they're like, oh my gosh, that's so much better than what I'm doing. I'm going to do that. And now when they finally get to a patient, excuse me, now when they finally get to a patient, they're going to sort of naturally fall in line because they've seen it in real life. I don't know if you've had the experience before, but a lot of times, I'm talking to patients and I have like the same phrasing that I'll use, or I tell the same jokes over and over and over. And then sometimes I'll be working in a room and I can hear my assistants or my hygienist use the same phrasing or use the same jokes, and it's so they naturally will sort of pick up on what's going on around them. It's almost like osmosis, which then calibrates them even further without them having to specifically memorize something. It's just, this is the way we do it in the office, and so we all do it the same way. Yeah.
Yeah, no, I 100% agree. If it's working, if the verbiage you're using works, you're not trying to create robots, but why reinvent the wheel? So if someone overhears something that they could acclimate to their own verbiage, then might as well use it. The other thing that I'll touch on is from a calibration perspective. I truly believe that if you are not intentional about having these conversations with your new associate, then they just won't happen. A lot of doctors that you and I coach, they say to us like, well, when we have the time, we'll discuss a case, or when we have the opportunity, and you never have the opportunity. Because the associate works late through lunch, or you work late through lunch, or at the end of the day, you got to leave early to pick up your kids, or whatever it is. So I just think in that first 90 days, you just have to be so intentional about scheduling time to do the little things that you're talking about. In our organization, it's looking at x-rays, looking at treatment plans, looking at clinical photos. Okay, what's the treatment plan here? What are you thinking when you see this tooth or this x-ray or this clinical photo? What questions did you ask the patient about, what their wants are, what their needs are, what are their obstacles to treatment? Like these are things that took you and I years to figure out. And if we can collapse time for associates and remind them on a consistent basis that these are relevant things that you're going to need to understand and have clarity on to be successful here, I just think we're setting them up for success.
Yeah, it's funny you're talking about 90 days. That the program that I run, the 90 Accelerator, came about because I've been a practice owner and I've been an associate and I've been coaching for a while now. And what I see over and over is exactly what you're talking about. Everybody has the best of intentions. The owner doc has the best of intentions. We're going to set aside Thursdays and we're going to talk once a week for the first whatever. And then pretty soon you gotta pick up a sick kid, or you got to pick kids up because your wife's doing something else, or the associate can't do it because of X, Y, and Z. And then pretty soon it just keeps getting missed and missed and missed. And at the end of a year, the associate's upset because he didn't get the mentoring that they expected to have. The owner doc's upset because they didn't get the associate never became profitable in the practice, and they created a whole bunch of problems for them.
Right.
And that's the point at which I started that program, because I'm like, I've been that doctor, and as an associate, I was never offered mentoring, so that's fine. But I've been that doctor, and I was thinking, I can like be the guy, like I can be the guy that will meet with you once a week, because we're going to meet, every week, and we're going to
Yeah.
do this for 90 days, and we'll go through all that stuff. And
Yeah.
the other part of that is, it's really good to sort of have a program, so that we're hitting all the things we're supposed to hit. And that was a question I was going to ask you: when you have your docs come in for 2 weeks, or 3 weeks or a month, and they're just going along with you and observing, do you want them to observe a certain number of particular type of procedure, or is it just like it's day-to-day flow, it is what it is when it comes in the door? What are you wanting them to do certain things?
Yeah, so it's a great question, and it's a little bit of both. So we do all of our onboarding at our flagship office, which is a big office, 5 doctors, 8 hygienists. There's a lot of chaos. Um, so you get exposed to a lot, but just to make sure that you're getting exposed to everything you need in our guidebook or our onboarding document, whatever you want to call it, we have an audit section in that document that assures us that you're seeing enough hygiene exams, you're seeing enough root canals, you're seeing enough triaging of emergencies, you're seeing enough denture consults. And then that guidebook needs to be signed off by whatever doctor's training that particular associate. So it just kind of guarantees that they're getting exposed to everything. Now, as you know, you can get exposed to something 1 or 2 times and not reference it for months, and then all of a sudden you have to kind of relearn it. But we're just trying to expose them to everything that they can possibly get exposed to here in the first month or so. Um, and it's been successful for us. So I'm curious. Give me I like looking at this from the other side of the coin. What's another guaranteed way that someone like you and I can cause an associateship to fail?
um, let's see. So I'll combine two. And I would say, don't give them an experienced assistant, and don't show them how to work with or train an assistant. So I'll tell you a short story. So I did a scratch start. I got to a point where I had to take a job because the scratch start was going slower than I thought. And I worked for a doc, and he gave me an assistant, and she was a 16-year-old high school student whose name was Angel. And Angel was a very nice little girl, and Angel knew absolutely nothing, and they did nothing to train her either. So here I am trying to train myself, deal with patients, and train Angel all at the same time, which gets to be a bit overwhelming. And of course, Angel didn't know where anything was in the practice. So every appointment took forever. And I didn't know about setups or think about setups and standardization and, these sorts of things. And of course, neither did she. She's a high school student. She was a warm body, basically. And so it was a fairly frustrating experience, as opposed to, you give the associate an experienced assistant, and now and tell him, listen to her, because she knows what's going on, or him. And a lot of times, if a doc is willing to be coachable, and that's a big deal. And everybody who's coming out of dental school usually was in the top end of their class. They've had to push through a lot of stuff academically. They tend to be fairly self-assured. And then you tell them, go listen to somebody who has a high school education and just happens to have been working here for a while. Sometimes it's a little hard for them to swallow. And the smart ones will realize that despite my education, that person knows more than I do. So I'm going to be talking to them. And then they can actually start to create a relationship that works, where there's give and take on both ends, and they're willing to accept some coaching, not only from the doc who's training them, but also from the assistant that they're working with. So if you give them somebody that's just brand new, then it just it's you're bound for certain failure, because they don't know where anything is in the office. They don't know what the process in the office. Just like you have to train docs, you got to train assistants, and it all starts to fall apart from there.
Yeah, 100% agree. And I think it's great advice, and advice that I give out a lot to coaching clients. And I'll tell you, the number one obstacle that I hear is, oh my gosh, I'm so dependent on my best assistant. I can't imagine giving them up, right? To which I say, look, like it's going to be hard in the beginning to give up your primary assistant, but you're going to have to slow down to go fast. And I've seen firsthand, I know you have too, when you give the new associate a really seasoned assistant, it just exponentially benefits them from a learning curve perspective on multiple fronts, right? So even things as simple as if they're giving injections that are uncomfortable, right? In their mind, they don't know what they don't know. They may have always given injections a certain way, and this is just how it is. If you have an experienced assistant that's ultimately thinking about the benefit of the practice, they're going to pull that associate aside and be like, "Hey, just so you're aware, like it's clear to me that these patients are experiencing discomfort when you give an injection." To which the doctor will typically say, "Yeah, I know it sucks. It's an injection. It's going to be painful." Then in the assistant can be like, "It doesn't have to be. Like there's a better way, right?" Because if you don't know that there's a better way, then you just don't know. Um,
Right. Right.
and with a brand new assistant, you're never going to get that feedback. They're gonna be a hermit. They don't want to speak up, and it's just a blind leading the blind. So I 100% agree with what you're saying. If you're the owner doc, suck it up, Buttercup. You're gonna have to deal with losing your best assistant for 60 days, whatever it is, until this one's up and trained, and then you can give them, let's call them an average assistant that you can ultimately train up to become your A assistant. But yeah, no question that giving them an experienced assistant is a no-brainer from my perspective. So I like that one a lot, Aaron.
Yeah, and especially when, if it's hard for you to work with a new assistant and you have 5, 10, 20 years of experience, imagine how hard it is for a new grad doc to work with a new assistant. Like you're just not getting anywhere. I mean, they're just feeling like everything's hard and difficult and et cetera, as opposed to at least you're an experienced doc. You know what this should look like. You have this assistant in there, and then you can kind of help to train her and move her along. And so you're actually sort of getting a twofer because your associate's getting trained and your assistant's getting trained. Now, if which a lot of times docs get associates because they want to be able to take more time off, they want to make their life easier, they want to be more profitable. Okay. And if that's all you're looking at, then yeah, don't give him your experienced assistant, but then you actually just shot yourself in the foot because it's not making things better. The other
Yeah.
thing at the end of whatever that period of time is, now you have two people who are trained, the new assistant and the new doc, who are both trained in the way that you want things to happen, and you've actually moved the ball down the field much further than you would have had you hung on to your primary assistant and try to let them figure it out by themselves. And then you have all those meetings with him or her, and then it's not working, and then you decide you need to switch associates, and you've started this cascade of negative events by not be willing to be a little bit inconvenienced by not having that primary assistant that you're used to working with.
Yeah, so true. And a lot to unpack there. I just want to add a couple things. Whenever we have an associate that's quote unquote inefficient, it takes them 2 hours to take out a tooth, or they're scheduling 2.5 hours for a crown prep. Like it's been my experience in going through a lot of coaching calls with owner doctors of, they're ready to make a change because the associate is just not fast or they're not getting it, right? But when you strongly encourage them to go into the room and assist the associate for a half hour and just watch what they're doing, you immediately pick up on all of the inefficiencies, coach them up, and then all of a sudden they're cutting their times in half. I'm not suggesting that the doctor has the capacity to do that a lot, but if you have an experienced assistant, one that knows the owner doctor and knows how to be efficient, knows how to talk to people, knows how it should be, that experienced assistant can look at the associate and be like, you should try this burr for the crown, or you should tackle it this way, or
Yeah.
have you considered starting your extraction this way? Or even report back to the doctor, not from a tattletale perspective, but if you're going to have weekly meetings, having it with the associate, with the experienced assistant, and with you, okay, this is what we were able to accomplish this week. Here's some of our pain points. Let's talk through these. So next week is even better. Um, and none of that occurs if you're giving the associate a brand new dental assistant that's right out of some type of program. So again, it's like the blind lead in the blind. The other thing I'll say, and just want to make sure that the audience hears the point that you just made. hiring an associate to free you up um, never is the result in the short term. So bringing on an associate is basically adding a part-time job to the owner doc from a mentorship perspective, from a weekly check-in perspective. Now, we'll unpack a lot of what you're doing now with young associates and collapsing time for them and teaching them how to be much more efficient with everything from communication to treatment planning to endo and extractions. So I do think there's an opportunity here where if the owner doctor has that skill set and the patience and the capacity to do it, perfect. But if they don't, then someone like yourself can be utilized to collapse time for that associate, basically representing the owner doctor from a mentorship perspective of that new or younger associate. Would you agree with that?
Yeah, yeah, absolutely. I mean, the thing is, just because you may be really, really good at whatever it is that you do as the doc clinically, et cetera, it doesn't mean that you can teach that, because some people can slash like to teach, and some people are like, I don't want to teach, get it in there, get it squared away. I talked to a doc one time and we were talking about the root canal course. He's like, well, I pull my associate over whenever I have a difficult root canal and I show him what I'm doing. And I'm like, that's great. Here's the problem. You have a whole framework in your head of what you're doing and what your steps are. And what you're doing is bringing him in at the end. He doesn't have that framework. You've forgotten that you developed that framework because it happened so long ago. It's just natural to you. And you would, and if he said that to you, you'd go, what are you talking about? Don't you know what you're doing? When what's really happened is you didn't know what you were doing either. You ended up going trying a bunch of stuff. Stuff didn't work. You figured out what did work. Now this is your framework, and you go through, and then you get to this piece that you think is a little challenging. You're bringing him in. You're bringing him in the last 10 minutes of the movie, and he didn't see the whole rest of the movie. It's like he has no idea what's going on. Where the end of the movie affects you greatly, and he's like, I don't get it.
Yeah.
So it's that too. It's that you have these are the steps that I go through. We recently did that hands-on extraction course, and one of the docs pulled me over, and they go through and they watch a bunch of online stuff before they come in, and then we take teeth out all day. And so the one guy, he really wanted to like do sectioning of teeth and taking out roots. I'm like, okay, great, here's some cases. And so he did one, and he called me over. He's like, okay, I'm not quite sure what I'm doing wrong. I'm like, have you tried this? He's like, yeah. Have you tried this? Yeah. Have you tried this? He's like, yeah. I'm like, do you mind if I take a look? I put my hands in there. I went through the three things. And I went, okay, pick up your handpiece, take away some bone. It's just that simple. But I had the framework. He had done
Yes.
all the things and he wasn't being successful and he thought it was his fault. And it's like, nope, it's just time to go to the next step. That's all. But if the associate doesn't have that framework in their head to start with, they're just like lost. And then pretty soon, I mean, in your organization, fortunately, there are other doctors around that can like bail them out. But for a lot of guys, it's like it's now a referral to the oral surgeon. And then eventually they decide that they're not really good at oral surgery and we're just going to send it down the road all the time. And now you've created a second problem because you've reduced the efficiency and productivity of your practice. And now patients just don't go, they don't want to be referred. They don't want to go to another office. They don't want to meet somebody new and figure out someone else's financial policies and et cetera, et cetera. So you've just created a bunch of issues that didn't necessarily need to be created.
Yeah, no question. That's so true. All right, let's do one more. Give me one more way that we can absolutely positively guarantee that our associate is going to be set up for failure.
Do not help them evaluate their work. So they just come in, they do the work. I don't know, root canals don't work. From now on, I'm just extracting teeth and putting in implants because that's what I know how to do. Or, hey, we tried to do this bridge and, yeah, it didn't work. And so I'm not doing bridges anymore. Or, if you have enough failures in any area, you start to go, well, yeah, that doesn't work. Despite the fact that there's how many thousands of dentists that it does work for. So something's being missed, and if you don't help them figure out what the thing is that's being missed, then they never get better. And that erodes their confidence. If you're confident in what you're going to do, and hey, if there is an issue, I can handle it, all of that helps to build up their confidence. Whereas if you're like, well, I hope it works, and if it doesn't work, it's like, I'm not very good at X, and they tell themselves that story over and over again. And then pretty soon they're not very confident. And so you always want to be doing things that are going to help, protect their confidence and develop their abilities.
So, because there's so many different things that we do in dentistry, I mean, this part of the conversation alone could be a couple hours. So let's try to narrow it down to fillings and crowns, right? Single unit crowns and two surface fillings.
Okay.
So I 100% agree with what you're saying is not giving feedback to an associate about the quality of their work or the clinical standards and what have you. So walk me through, Aaron, what your ideal framework is for helping a new associate evaluate not necessarily the need for the work. That's a conversation, it's a treatment planning conversation, but
Sure.
the results of the work. So how would you best encourage us to communicate with our associates about, okay, you've done this filling, you've done this crown, let's evaluate now how successful it was.
Okay. So if you're talking about a filling, let's talk about class
Yeah,
twos, because that's everybody's nemesis.
right.
And so we take bite wing X-rays after every class two restoration until they've gotten through that part of the training, and we notice that consistently there's an overhang on the gingival wall of the box, and so we say to the associate, hey, so there's obviously an overhang here. We got to kind of get this squared away. Did you notice it when you put this in? What was going on? And they might say something like, well, I put the band on and I put the wedge in and I put on that little ringy thing and then I just filled it up. And, this is what we ended up with. And I tried to remove it with a scaler and, this is as best I could do. Um, and then, you might show them a picture of a properly placed band, okay, and say, see how this is all tight down here and it's not open. And he's like, well, I did that and I put the wedge in and then it was still open on that other side, but I couldn't do anything about that. And say, are you aware that those plastic wedges are actually made to have two wedges put in, not one from each side? And this is how you do it. And most of the time that will close up that little space and you won't have this overhang to deal with. Or maybe the answer is we always put in a layer of flowable first, so we're not pushing the band out and creating a problem. It's like, oh, I never thought of that. Or hey, maybe they'll say, I put both wedges in and I still had a little gap. And say, well, have you ever considered taking some Teflon tape and stuffing it in there between the band and the little ring thingy or the wedge to close that up even further so you can really customize this band? And now once you fill this up, you have very little flash to deal with and you'll not have these overhangs. So all three of those things they may never have heard of, and may never have gotten it in school or any program they've ever gone to. And so there you go. There's one option. And then maybe with crown bridge work, delivering a crown on the terminal molar is always interesting because it'll go down and you can get a nice contact, but it might be that the contact's still too tight. But since it pushes the whole crown to the distal, what you end up with is a mesial margin that doesn't meet up with the mesial margin of the crown. And so it's like, okay, you need to be really careful with these. And when you're noticing this, adjust a little bit more and then put it back in and notice the contact. And for me, I'll put it in, have someone hold it, and then I'll keep adjusting. And once the contact starts to get lighter, then I know that I actually probably have it seated all the way. You can also check and explore it and do those things and just talk to them about this exists and this is sort of a known problem in these situations so that now they're looking for it rather than being surprised by it.
Yeah. I feel like I'm gonna sneeze 1 second. Maybe not, right? uh yeah, I 100% agree with everything that you just said. So I've had associates that have been doing dentistry for 8, 9, 10 years join us and see some of the work that they do, and lied to myself that, well, they've been doing it for 10 years, so it must be good, right? But
Yeah.
giving them the benefit of the doubt, maybe they just didn't know what they didn't know. So based on those experiences that I had early in my career, I think it's so important. And again, for us, it's this first 90 days to do all of these audits. And not because you're trying to micromanage, but you're just trying to collapse time for this person and explain to them, this is a good class two. This is a bad class two. This is a good single unit crown scan. This is a bad scan. This is enough clearance. This is not enough clearance because they don't know. And when we assume that they know because they're a licensed dentist, that's, in my opinion, when the wheels start to come off. So over communicating, especially in the first 90 days, what the expectation is, what is good, what is not good. realizing that they're not going to be perfect, but just like growing, learning from our failures, I think it's so important. And I totally agree. I'm not trying to give radiation exposure to everybody, but taking bite wings for fillings, um, for the first 90 days, for crown deliveries for the first 90 days, we will insist that the doctors take photographs of their preps for a filling, and then giving them the permission to say, if you're not sure, come get me, right? And then having some type of excuse in front of the patient. Well, Dr. Jones is using this brand new bonding agent that I've had experience with, but I wanted to walk him through how to use it, right? So the patient's like, oh, okay, as opposed to what, he doesn't know what he's doing. We do
Yeah.
that all of the time with implants. I mentor a lot of my associates to place implants, and I'll walk in the room and I'll say, Mrs. Jones, uh, Dr. Smith has placed a number of implants, but this is a new system that we're incorporating into the office, and I just want to make sure that they understand the order of things. Oh, okay. And then you could actually just start talking over the patient. They've tuned you out. They don't want to hear you anyways. So it's a great way to get into the room and do that direct mentorship, and not have the patient start to second guess the clinical experience. But yeah, everything that you just said. I mean, just you could spend an hour talking about how to wedge a tooth, to prevent overhangs and get a great contact. And in that hour, you could collapse so much time for the associate versus them having to figure it out over 18 months of the right way to do it. So 100% agree with what you're saying.
Yeah, I mean, I know when I talk to docs and and we talk about doing a quadrant of class twos, and everybody goes, "Oh my God, class twos," and they go, "Well, this is the way that you can set the bands up, get everything squared away, so that you don't have to go back and do a lot of finishing, because that's where a lot of the time comes in. They do that, or they're almost single surfacing the whole thing all the way through, so they're not laying out a whole bunch of bands and wedges. They're doing them one at a time, which takes forever, because then you have to go back and re-rinse and re-etch and all that kind of stuff, and then point out how to do it so that there's not a lot of finishing in the end. And all of a sudden, their really long appointments for class two composites get reduced by a third,
Yeah.
and it's just taking care of these little details that make the whole process go along faster. And they just haven't spent the time, doing that sort of thing. Um,
Yeah.
we typically will survey the assistants anonymously about how the doc works, so that we get because we have what we think we do, and we all docs, it's like fishermen, all the fish are always this big, and so you want to find out what really happened. And so you
Yeah.
get them to kind of fill out some questions. It's like 7 or 8 questions. And we had this one associate, and the one assistant, she worked with four of them. That was all anonymous, but this one assistant consistently was like really hard on her, like really, not happy with her at all. And a lot of things she pointed to was, confidence, and it said it's speed, are usually the two things. And this associate went through the program. At the end, the owner doc sent me a thing and showed me her increase in production, which was like 30%. And I ran into that associate at an event, and I said, "How's it going? You've been done for almost a year now." And like her face lit up. She said, "Oh my God, the assistants want to work with me. Like it was such a struggle before, and now dentistry seems so much easier, and the assistants actually like working with me, and my production is up, and all these little things that we institute in place, and all of a sudden life is better. Things are smoother. She's faster. Her owner doc is happier with her. The people she works with day to day are happier with her, and she's life is gotten better. So that's always like the coolest change. And we're really, yes, we want them to be productive for us, but it would really be nice if they're happy in their work, and they're
Yeah.
happy treating patients and do a great job, et cetera, et cetera.
Yeah. So there's so much more that we could talk about. I'm sure your list of ways we can guarantee to set the associate up for failure is probably 10 or 12 long. We haven't even really gotten into like the emotional intelligence part of it, the ability to communicate, maintain eye contact and stuff like that. So we'll have to have you back and kind of unpack a lot of those things. It's the chicken or the egg, right? Is an associate underproducing because of their clinical abilities, or is it because of their inability to communicate with patients, right? Every day it's something different. Um, so to your point, or to the conversation that we're having, if the owner doctor has the skill set to teach, has the patience to teach, has the capacity to teach, then I would guess your recommendation would be that owner doctor should spend the time and the energy and the bandwidth to train up their associate. But the reality is a gross majority of owners just don't have the capacity, the patience, or maybe they're just not teachers at heart. So in situations like that, if we're trying to set our associate up for the most successful process possible, how would your wisdom, your courses, your curriculum be incorporated into that process?
Yeah, good point. Yeah, so like you said, even though you might be able to teach, willing to teach, see that it's important, are you willing to take clinical time out to go teach another doctor? And if the answer to that is no, or it's something always just seems to get in the way, that's where I'm like, I understand. I've been that guy, for sure. And that's part of the reason, the impetus for doing a lot of these things. You can always send them to a course. We do a hands-on root canal course and a hands-on, it's actually root canal and crown, and a hands-on extraction course. You can always send them to the course where they can get some hands-on experience, which to me, you have to have some level of hands-on before things sink in, and you've seen, well, where the tight spots, where's the pitfalls, et cetera, et cetera. For me, when I'm teaching courses, I always give out my phone number, my email address. It's like, send me, text me, let me know. Before I got on with you, I was answering two different docs about issues that had come up, and they sent me pictures and radiographs. I'm like, okay, you always said this. How do I do it here? And I was in the middle of typing out an answer. I'll go back to that when I get off, to give them ideas about how to solve that particular issue. So that's really helpful. With
So, so that's the hands-on stuff. Tell me, unpack a little bit of the accelerator course.
Okay. So the 90-day accelerator course is online clinical coaching. We meet for a period of 90 days, and we meet twice a week. So on Monday, we're going to meet for an hour and a half. It's only 6 to 8 docs because I want it to be very much seminar style, very much we're going to go through everybody's thing and talk about it, because either you have the same problem that they have, or you've solved the same problem that they have and you can add to their knowledge, or you're going to run into this problem eventually. It's just, and so by having those discussions, it puts them a little further ahead. And we're going to go through a lot of things like batching, which you and I talked about, where you pick up the handpiece, you put in the burr, and you do everything you're going to do with this burr before you either change burrs or put down the handpiece. And that alone is going to change the way that you go through your procedures. Then the thing we always tell them is, hey, it's going to feel uncomfortable because this is not the way you've always done it. So you need to be clear on the fact that you're getting the results you're getting because of the way that you're doing what you're doing. And to get different results, you have to change what you're doing. So you're going to need to be willing to be uncomfortable for a little bit. So we'll talk about batching. We'll talk about treatment planning. How do we go through when a patient comes in, this tooth is killing me, or this tooth I think is ugly, I want it fixed. And they have a whole bunch of teeth with, decay and periapical abscesses and all kinds of stuff like that. How do you bring them in and get them okay and take care of everything that needs to happen? How do you get in and out of a hygiene room and have it not take 15 minutes and still see the patient, have them feel connected, et cetera, et cetera? So we actually make them record themselves, going into a hygiene room and doing that exam. It's painful watching yourself, but it's really useful. Okay. And so we have them go through that. I also send them a little black box of all my favorite things that I think will help them reduce their clinical time doing various things. And then we talk about, okay, if we're doing extractions, what's our decision tree look like that we're going to go through? It's the same every single time. If we're doing a root canal, what's our decision tree look like? And it's the same every time. If it's taking you 20 to 30 minutes to cut a crown prep, okay, I'm going to give you an exercise. You're going to have to collect some teeth, and I'm going to have you cut a bunch of crowns in a particular way. And it's gonna take about an hour to an hour and a half of your time above and beyond either sitting and talking to me or doing clinical dentistry. But it will take you from, we had one girl who went from 18 minutes down to 6 minutes within an hour. She invested an hour of time, went through the exercise, and in 1 hour reduced her time by 2/3. And that's just, you see those kinds of things, and that's kind of crazy. We make
Yeah.
them time all their procedures. There was a consultant that wrote an article recently in one of the dental journals, and he said most associates could increase their production 30 to 50% simply by knowing how much time it actually takes them to do a procedure. And then once you start timing the procedure, we want to look, time the appointment, time the procedure, okay? Because those are two different things. Maybe the problem is that the patient's butt doesn't hit the chair till you're 20% of the way through your appointment. You're going to run late. You just are, that's why you need extra time. So you want to solve the problems that they actually have. Yeah, so it's mostly those things. We go through all the different disciplines of dentistry and talk about ways to streamline things and to reduce time and to make things more efficient, to spend less appointments. Because a lot of times we keep bringing patients back for appointments because it's comfortable for us, whereas we could do 2 or 3 things in that one appointment that is going to make things work out a whole lot better. And then we also talk about, everybody wants to talk about, quadrant dentistry, full mouth dentistry, et cetera, et cetera. It's like, and that's not a full mouth of crowns. That's like, maybe we do the fillings, the root canal, the crown, the extraction in one quadrant, in one visit, with deliveries later on, obviously. And maybe that's our quadrant dentistry, which is much more productive than bringing that patient back 4 or 5 times. And they do get to a point where they just have appointment fatigue. It's like, they keep coming, they keep asking off, they keep having to get their kids shuttled off here and there. And so the more that we can condense that, the number of visits for the patient, the more successful that associate's going to be and the more productive they're going to be also.
No question. Yeah, I take my own medicine. So, Aaron and I were talking before we hit record. Aaron's been up to my group and mentored a lot of my associate doctors on the 1 hour molar endo build up crown, and just delivered so much value to my doctors. And I was sharing with Aaron that we had our monthly doctor call last week, and they had actually asked for Aaron to come back and teach more. So I wouldn't be bringing him on the show if I didn't truly believe that he can bring just a tremendous amount of value. He has it in our own organization. And I know that if you are an owner out there that has an associate or two and you just don't have the bandwidth or the skill set to train up your associate and you want to get them to the next level, we outsource insurance verification, we outsource AR. This is something that you can also outsource. And to be 100% honest with you, it'll be done at a better level than you could probably do. So if you want to reach out to me and hear about my experience with Aaron coming up to the group, as you guys know, my email and my cell phone are on the website, dentallighthouse.com. And then, Aaron, what's the best way for the listeners to get a hold of you or to learn a little bit more information about your offerings and what would be the next steps if they wanted to engage in a relationship with you?
So there's a few different ways. They could go to mondaymorningdentistry.com. So www.mondaymorningdentistry.com. And then there's a number of free things there. All the courses are right on the front page, so you don't have to go digging through the website. There is a testimonials page, and you can see what other docs have both written and video, kind of what their experience has been with the extraction course, the 90 accelerator, and the molar root canal build and crown course. You can reach me by text or phone call, 410-207-3527. 410-207-3527, or send me an email either through the website or my direct email address is anicholasdds@gmail.com, anicholasdds@gmail.com. So far, no one has abused any of those, and so I keep giving them out. And so, I'm happy to be contacted on any of those in any of those methods.
Well, I so appreciate the time, Aaron. I learned a lot, and it's just nice having a conversation with someone that's has some scar tissue and some brain damage based on these things. And hopefully, the listeners, I know that they've learned a lot, and they'll either be motivated to take on a lot of this responsibility themselves or outsource it to an expert like you. So I really appreciate the time and you coming on the show.
No.
Ladies and gentlemen, jolly old Doctor. Did you have something else you want to say, Aaron?
No, I was just going to say thanks for having me on. It's been a fun conversation, and I'd be happy to come back if you get requests and you need me back.
Yeah, no doubt. Thanks again, Aaron.
All right, take care.
Thank you. That wraps up another episode of the Dental Lighthouse podcast. You have a choice today. Choose to be a lighthouse. Lighthouses are powerful and steadfast. They are beacons of light for others to reference when life gets turbulent. Go out into the world today and become a lighthouse for someone. Give more than you get. True joy comes from serving others. Start today. I'm Jason Tanoory, your host. Thank you for listening to the Dental Lighthouse podcast. For more information, podcast show notes, or links to anything that we have discussed today, please check out our website, thedentallighthouse.com. We would love to hear from you. If you would like to get on the show, please email us at podcast@thedentallighthouse.com.